Hi guys. So for those of you who don't know me, I'm Suvam, one of the PGY4s, and I'll be giving like an admin lecture today on observations, kind of like a primer in general. So we'll go ahead. I think it's always interesting to learn about just the history of medicine, since it sort of informs the context of how we practice things today. And so my outline kind of start off with just like the historical timeline of observation. And then we'll go ahead and talk about like the financial and like the medical, the healthcare policy that informs OBS in general. And then move forward into like the principles that define observation care, the benefits of OBS, and then just some physician perspectives. And we can kind of open that up to the audience to think about what they find to be helpful or not constructive about observation care. This is Hippocrates, who is known as the father of Western medicine. This quote comes from his Hippocratic Corpus, which is a collection of ancient Greek medical works that essentially are associated with his teachings, medical, non-medical, philosophical. And as you can see, the idea of observation really has been fundamental to how physicians care for patients since the very beginning of man, I guess. And he's arguing that to really understand the nature of disease and of humans in general, it's best achieved through the act of observing their condition over a period of time. And so while the medical concept of OBS really spans millennia, OBS as like a model of care has only really been around for some 60 odd years, basically. And what's interesting is that if you look at the literature, it kind of coexists along the same time frame as the formation of emergency medicine as a specialty too. So we're kind of like twins in that perspective. The first formal mention of observation comes in this article in this journal called Hospital Forum in 1965. This like resident who worked at this Kaiser hospital basically reviewed like 1,000 cases of people that were admitted to their hospital, and was the first one to describe the use of observation beds in the emergency service units. And what they recommended was that an OBS stay should not exceed 24 hours. And so I think like keep that in mind. Also be careful what you write and canonize when you publish your papers, because you don't know what's going to stick like 60 years later. But this is like fairly important because this kind of defines your care today, actually. The 70s, you saw like the onset of research into short stay units. So less than 5 days sounds like an inpatient admission for us, but back then this was seen as like an alternative to like a possible inpatient hospitalization. And so this was targeted care for patients who needed brief hospitalization. Specifically, it was for pediatric and surgical patients. But from there on, we kind of generalized to other presentations and cases from there. And so I think when I think about OBS, I think about chest pain and ruling out MI. That's kind of like the canonical sort of like reason you put someone on OBS, essentially. And so the 80s, you saw the beginning of protocols for chest pain. And what's interesting is that before the 80s, you essentially admitted almost every chest pain patient to like the CCU. And so this obviously is not very feasible or financially like, solvent. And so you saw like the onset of like the beginning of protocols, basically, to see like who had actually been from hospitalization, who can be discharged. But it wasn't really until the 1990s when you had a lot of federally funded randomized control trials that refined the workup for chest pain at large. And so this is when the term accelerated diagnostic protocols, or ADPs, enters the medical lexicon. And essentially these are dedicated chest pain protocols, which from the evidence showed like better outcomes for these observation patients compared to inpatient admissions. And you saw the same for asthma as well, actually. And ACEP formalized the scope of OBS by creating the first OBS unit guidelines. This is 1988. And then in 1991 was when the section for observation medicine was fully kind of like constructed. And then from there, obviously you have expansion of research into more indications and to create like an evidence base for observation. And then now more like recently, I guess, there's a shift more towards health policy, improving health systems, because the bigger question really is how do we optimize this like industrial complex, and how can we save ourselves from just the fiscal catastrophe that's about to ensue? And so the medical research is great, obviously, but it really wouldn't amount to anything as important or prevalent as it is today without just this very intense fiscal reality that we have to face as physicians, as policymakers and stakeholders. And so we obviously are all pretty familiar with how fragile our healthcare system is. These numbers are from like 2014-15, really. They have like the most comprehensive like observation data sets, and so that's why I'm using this. This is obviously an underestimate of what exists today, but pretty staggering numbers, as you can imagine. And as our population increases in ages, you have more people coming to the ER, COVID notwithstanding, but you're getting more admissions to the hospital. You see a surge of demand for inpatient beds, and this creates a lot of demand, obviously. From the $3 trillion that was spent on healthcare in 2014, about a third went towards hospital care. And CMS, the Centers for Medicare and Medicaid Services, they're the ones that develop medical policy, really. So they end up spending about like $400 billion on these payments. And then obviously inpatient care is a quarter of all Medicare spending at large. Some very brief basics on Medicare as they relate to observation and inpatient admission. There's different types. A and B are the ones that are a little more salient to this talk, but Medicare A is what covers your inpatient admissions and like your nursing home placements and SNF care after admissions, compared to Medicare B, which is for your outpatients, which include ED providers and what the care we provide, OBS and like clinics and so forth. So really it's this financial fragility and the attempts to reduce costs is what has codified observation as a legal and structural entity. And so to control rising hospitalization costs, Medicare has kind of implemented various like controlling mechanisms. And so I think these three are some of the more like important ones for us to kind of recognize and understand. DRGs were first developed really in 1983. Medicare launched this inpatient prospective payment system, and they adopted the payment methodology that are DRGs. And so essentially it makes kind of sense where you're only going to get money for specific conditions that correspond to specific codes, right? And then to save more costs, CMS, and this is more recently, like the early 2000s, they developed these auditing contractors. And these contractors, they retroactively audit claims and recover money if any overbilling occurred from inappropriate inpatient status, right? And as you can see by the numbers, there are a lot of inappropriate inpatient admissions. Almost half the overpayments that they basically like got back was due to these short inpatient admissions. And I think in 2013, about 93% of all hospitals in this country experienced some sort of auditing activity, this hospital included. And about $2.6 billion in denials were reported, basically. And so as a result of all of these sort of like stressors, Medicare actually introduced observation services where the idea was to manage the patient as an outpatient in a bed in the hospital to kind of like cut costs, like save money. But of course, what this meant was that you had a lot of people now being placed on OBS for like a long, long period of time. And so we then react again by creating this 2 midnight rule. And so this is also kind of pretty important to know, but OBS ends up being like it's like a criteria for placement into OBS status versus like inpatient admission, and it's time dependent basically. And so you need to be hospitalized at least 2 midnights to count for an inpatient admission. If it's less than that, then it's observation basically. And this rule is implemented to decrease like, the auditing committee pressures, to decrease prolonged observation stays. And the presumption on the end of reviewers is that admission will not be scrutinized as much if patients meet this kind of benchmark. Obviously it gets more complicated than that, but the thing to note is that observation time does not count towards this. And so what ends up happening is you create a population of people that are basically, quote unquote, too sick to go home, but not sick enough to be admitted inpatients, right? And so this is the CMS definition of observation, kind of like verbatim. And you see here again, that 24-hour thing that this random resident in the 60s kind of like, just kind of like thought about, and this is what we have as policy now. So shout out to that person. But 24 hours is like kind of like the big number to like take into mind. And then 48 hours is kind of like this max. And really like the point of OBS is to figure out like who needs admission and who can be discharged within like 24 hours, like a brief focused period of treatment and monitoring essentially. And so this is ideal for people, with like somewhat uncertain diagnosis, like chest pain, real MI, people with like clear diagnosis that just require short-term treatments like asthma. And so that's kind of the idea. And so it ends up being this potpourri of like a bunch of different things, right? That's like a billing designation, like where is the patient located in the hospital, clinical status. But fundamentally, OBS was created to mitigate just like the reimbursement reductions and payment reductions from Medicare. And so observation care, like ED care, is time dependent and defined by time. And specifically, your hospitals are penalized if your inpatient length of stay is less than 24 hours. And so the real question becomes like, what do you do for these patients that require care between this like 6 and 24-hour period? Because what ended up initially happening was that these people were either like inappropriately admitted too frequently, or they were discharged a little bit too rashly. And so this is where like maybe like the OBS unit comes into be kind of useful for these patients. And so observation occurs roughly in like these 4 different types of settings. I circle type 1 because that's, for the most part, what we do at Kings County. It's like a type 1, type 2 hybrid where you have a dedicated OBS unit run by like ED physicians. We obviously have like some other like subspecialty services that are also part of it too, but the type 1 units are the ones that have the best evidence base, really. But it's only like a sixth of all hospitals who have observation care, like actually implement type 1 OBS unit. And this is what's been most studied, has shown to have the most savings for patients, for the hospitals at large, and have been associated with the best outcomes. But once again, like most hospitals don't do this. In contrast, type 4 over here, which is like the discretionary care bed in any location, this is what's done in most hospitals in this country. And I think this is what is done in downstate as well, where it's like a patient's basically admitted to like an inpatient bed, but they're under like OBS care. And so the issue becomes like, this isn't like a protocolized thing. It's kind of up to the discretion of the providers and the teams, and people aren't like really clustered or centered in like the same location. And so it's all across the hospital. At Lutheran, they call this scatter OBS. But so like the fact that, you know, there are these different types of observation settings, you know, creates this like stratification of like outcomes and like effects for patients. The highest potential for cost savings, patient comfort, and hospital bed use efficiency lies in having a dedicated type 1 unit, but most places don't have that. In terms of like, so now that you know, like sort of like, you know, different types of settings, who should you OBS and who you shouldn't OBS. And so you come to the conclusion that a person has to kind of stay in the hospital, and you're trying to decide, okay, do we admit this patient? Do we keep them just for observation? And so once you get to that point, you have to kind of decide, okay, is this diagnosis actually billable or not? And you can actually look at the Millman criteria. And this is actually beneficial because if you are able to identify that this patient has a billable diagnosis and they're like going to stay more than 24 hours, you should be admitting that patient, because this is how the hospital makes money. This is how we are able to give nice things to our patients, hire more nurses, do all the nice things that our patients need, right? But if your patient does not meet any Millman criteria, you should consider OBS for that patient. And then if you go on Clinical Monster, we have all these different protocols that are in place about like different kind of protocols that are here. And the inclusion and exclusion criteria. So definitely be familiar with those things, but that's fairly salient. And then if you go on Epic, right, when you click on the observation, there's like these 2 things you have to choose between, which is like diagnostic uncertainty and therapeutic intensity. And that's kind of what this gets to again, where the idea is you have either like a single focused kind of like condition you're working up. And so the workup's like very like straightforward. And like, you know, if it's for chest pain, you get your EKGs, serial enzymes, you know, plus or minus like provocative stress testing, like that kind of stuff. Versus like for like an asthma exacerbation, for example, like you have a diagnosis, you're just treating it and reassessing the patient like frequently, essentially. Or if it's transfusion, you transfuse, reassess, then discharge. And in all these situations, you have a very clear idea of how long the patient will likely stay in the hospital. And so that's like a good OBS candidate, right? The people that you shouldn't be OBSing are the people that need very extensive workups. So like the classic patient is like the neuro patient that's sent from clinic, who they're like, they're blurry vision, maybe headache, weeks, months, who knows, but they need an MRI, they need an MRA, they need an LP. Maybe have rheumatology come see this patient because someone sent an ESR that's mildly elevated. Oh, maybe neurosurgeons see this patient too, right? And so like this patient really just should not be OBS because you don't really have a clear endpoint to what their care is going to be or where they're going to go. And so that should be admission or just like a discharge for outpatient workup, but that's not a good OBS candidate. If you push back, people are kind of like trying to put that patient on OBS, really. And then the last point, the one that's bolded, is actually, it's not as relevant for us at county because we're a little bit insulated from this, but nursing home and SNF placement, this has huge repercussions depending on like what kind of insurance status you have, because it's Medicare. Type A is going to pay for your SNF, but Medicare B, not really. It's going to be like patient outpatient costs, actually. So this is something to be mindful of when you decide to put people on OBS, if you're working at like a private institution with different kind of payer mix. So now that you put the patient on OBS, right, like they should actually be on OBS for at least 8 hours, because if you don't meet that kind of like 8-hour rule, you don't get any Medicare payment for clinical or facility fees, actually. And what's interesting is that the ideal OBS length of stay should be exactly 8 hours and like some minutes, because after that point, you actually don't get any more payments for keeping the patient longer than that. And so if you have the patient on OBS more than like 24 hours, it's actually inefficient use of your OBS unit. And so keep that in mind as well. So like your sweet spot really is going to be like between the 8 and 24, essentially, leaning more towards the 8, really. And then what's interesting also is that, you know, when you upgrade people from OBS to medicine, not the most cost-effective thing, And so this was kind of like seen through the various research where, once you had OBS care kind of being like, canonized, a lot of people have been putting everyone on OBS to kind of avoid all these costs associated with like auditing. But then they ended up getting upgraded, and what we ended up realizing was that, you're only getting paid for like one DRG basically, and you're just incurring more costs to the hospital without any additional revenue per se. And then your patient might actually be saddled with more costs as well. And so if you think the patient actually has a global diagnosis, and they're likely going to have to stay for, at least, 2 midnights, then you should submit the patient from the outset, essentially. The numbers at Kings County, so we ended up having like maybe, it's greater than 20%, which like that's the industry standard, where about 20% of all people end up being upgraded from OBS. We have a higher number than that, but I think we have a good explanation for that too, in that like we're pretty aggressive about discharging a lot of patients who, a lot of hospitals, you just like put them on OBS because it's like a money-making scheme, right? Like for chest pain in particular, like they're put on OBS, they get a coronary CTA, they get stress tested, they get echoed, they get a huge like bill. We don't really do that here. A lot of people with heart score 4s, 5s, we even discharge from the ED. And so the people we put on OBS, obviously they're a little more medically complex in that way, but also they have a lot of like other psychosocial comorbidities going on, and there's a lot of social things we have to kind of deal with too. And so that kind of changes like the players kind of like who are placed in our OBS unit. And so it's a little bit different than what like the hyper economically focused OBS unit is supposed to like function as. But I think the other thing to take away is also that when we upgrade patients from OBS to inpatient, and Dr. Yusuf made like a good point about this to me actually, is that he sees it more as like, we're really doing it to free up space. It's not only about billing so that other people in the ED who I think like might be like a risky discharge can be then placed on OBS. So it's a way of sort of like helping your colleagues in the main, especially, to mitigate their risk essentially as well. And so if you have someone you wanted to put on OBS, but you don't want to discharge, but there's no space, if you're able to kind of like create these avenues where you can upgrade some patients because they're going to need more time, that actually frees up a spot for them to be in the hospital, be re-observed, re-evaluated. There's a patient like I think yesterday, the day before, who basically, classic case, right? Like they're dizzy, they're a little bit older, they have some waxing mental status changes. They put an OBS for like possible syncope, right? OBS is able to see the patient. It was a busy night in the pod overnight, and so they see the patient, they examine the patient, get a little bit more history because now they can get collateral. Patient's been kind of like having a change in mental status that's been being worked up outpatient for like an MRI. But so they get a CAT scan, they see a brain mass, right? And so this is a good save because this person was, I think initially they were trying to discharge this patient. But you discharge this patient, they come back maybe days, weeks later, they've herniated and they've died. But in this situation, you have repeat observation, reassessment, you get like more of a workup. This patient is now admitted to the hospital essentially. So that's a good save, I think, for the patient, right? The national industry standard is that you want to discharge about 80% of patients home. And if your units are actually discharging less than 70%, you should actually change your guidelines most likely. And so those are kind of like some general kind of like time and billing numbers to keep in mind. And so I've kind of like gone through like just this rigmarole of just like, like financial kind of like barriers, things that you have to consider that are like outside the scope of just clinical practice, right? And so like, it sounds like there are a lot of like drawbacks and challenges, right? There's a whole bigger question of do you actually need to OBS patients, which I think a lot of people have like very strong feelings about, right? Like, do you actually need to OBS people for chest pain? Do you believe in ACS as a diagnosis? Syncope, is there any actual benefit for syncope and OBS, right? That's a whole different conversation, a whole different talk. So that's something to like always kind of think about too. And then really you have like the reality of what happens with patients on OBS versus what CMS dictates, right? Like you're supposed to be having these patients for 8 to 24 hours, but in reality, people are staying on OBS for like much longer. And like the actual hospitalization and how things work is more complicated, but you have length of stay creep, right? You try to be like a financially solvent like OBS unit. And so you want to have more patients come in, but then that kind of widens like who you keep in the hospital. Like it's not as like protocol based. And so now you have like a lot of people on OBS maybe shouldn't be on OBS. And so, that kind of like creates a burden of itself too. And then, the fact that most OBS units aren't really optimized to function like at their, peak, and because they're not type 1 units, right? Because most hospitals only really have these type 4 units where people are admitted to inpatient services. And they're kind of like all around the hospital. So, there are a lot of like sort of drawbacks really to how OBS is sort of like structured currently. And then the big one really is the fact that there's this concern for possibly like, just like dropping like a huge medical bill on patients, especially if like they think they're probably gonna go to like a subacute rehab or like a nursing facility afterwards, right? This can be a huge cost, and you need 3 midnights, basically, or three days of inpatient admission to be able to have the patient covered via Medicare. The unique thing about placement on OBS at county is that we're placing people in nursing homes from OBS, and it's not so much of an issue, but that's because we're placing people in city subsidized nursing homes, city contracted, H&H affiliated. And so that's very different from the private world, where it's going to be like different payer mixes, and you have to kind of take into account like how much the patient might be able to afford, right, with their Medicare. And so that's like a pretty big thing where OBS definitely can have some drawbacks for certain patients. And then I think at the end of the day, right, this can kind of provide this like this moral injury and fatigue about like, what are we doing, right? Like, is this really about patients, or is this about money? And like, are we just protocol monkeys, or are we just like now taking everything on, right? So that's a lot of things that are kind of going into people's heads about like, what is the point of OBS? But I think like from doing this like presentation, like looking more into evidence-based in the research, I do think that OBS is beneficial for patient care. And then, there are a lot of like economic benefits, and then just in general, like how the hospital functions, it functions better with like a functional OBS unit, actually. And so like for the business case, we're going to talk about the dispo for patients who don't meet like admission criteria. But also you save the hospital a lot of money by avoiding these inappropriate admissions, and there's less of a revenue loss that occurs. The thing that I think we don't talk about as much is that if you have a functional and robust OBS unit, you're able to clear out your ER in a very efficient way. And so this generates more revenue because you're seeing more patients, but you also have less crowding. Then you have fewer people that are kind of like leaving before they're being seen. And there's a lot of evidence to show that like, there are very poor outcomes with high left without being seen rates, which makes sense, right? Because they're not being evaluated. So they're just kind of going out into the world. And so these are all things that are like very tangibly, achievable with like a very functional OBS unit. And then of course, like just the administrative side of having fewer denials and just needing to hire fewer people who have to deal with all these kind of denials as well. And so the main benefit comes from like your type 1 units, the one that we circled earlier. And these numbers come from this study from Atlanta, Grady Hospital. This man named Mike Ross, essentially, his name is on like all these OBS papers, essentially. But this is a financial analysis of data from Emory, and then they compared Emory to like Georgia as a state, and then kind of extrapolate to like the US at large. But you can see some pretty impressive savings, and like significant decrease in length of stay, fewer people being readmitted later, hospital costs being decreased, and then this like overall like estimated savings across the country. This is obviously like an estimate, but we need all the money that we can get, right, from savings. And so this is the idea of why OBS is kind of beneficial from a financial perspective. And then I think going to kind of what we're here for, like what the clinical case is, right? And so I think as EM physicians, right, like our whole onus really is that we're really good at observing, frequently reassessing, and like thinking about how the patient's doing. And so this is what observation care really is about, right? They found studies showing that like patients have much higher satisfaction, especially with asthma and chest pain. And it kind of makes sense, right? Like you're moved to like a more part of the ER, you have a very direct plan, and the care is very expedited. And so you leave the hospital kind of like feeling better, knowing kind of like what, the steps are. And then the patient satisfaction part's like a huge thing, right? Because this is going to be more and more of like a metric that we have to take into consideration. And so that's like a pretty like good benefit there. And then really because you're keeping the patient longer, right? Like you have more time for diagnostics, and you have more accurate diagnosis of patients and like what they're coming in with. And then I think what I wasn't as aware of, but now, coming and working in the hospital for like a while now as a resident, but there are a lot of bad things that happen to people when they're admitted to the hospital. And if you can avoid that, that's the best thing you can do for the patient. Just like the amount of like drug resistant organisms that exist, right? Patient falling, medication errors, deconditioning, you can kind of go on and on about this, but OBS helps to avoid this, since patients are only being, don't being kept in the hospital for like maybe max 24 hours or so. And so that's kind of the point of OBS. And so there are a couple of different protocols. You can look at the protocols that we have on Clinical Monster too, but we'll just kind of like briefly go over some of the evidence base here. This is the evidence base for TIAs. Actually, I talked to Dr. Yusuf about this, but the average length of stay at county for an inpatient admission for a TIA is actually 4 days. So that's a long time for a patient that doesn't need to be in the hospital really. And so if you have a good OBS protocol for this, right, like you're discharging these patients after they get their imaging that they need, you're saving a lot of money, and then they're getting the workup that they actually benefit from, right? Same thing with chest pain as well. Our length of stay at county is obviously limited because there's a roadblock in terms of when they can get their echoes, all these stress tests, all these things that cardiology recommends. But in general, with OBS, you've had fewer admissions to the hospital. You're making more money because of that. And you're actually missing fewer MIs because you're having serial evaluation and observation of these patients. It's almost like $3 million saved at the hospital studied in this paper, like done in the early 2000s. And it's because you have fewer inpatient admissions and more discharges, essentially. Even though more people are undergoing more testing with like troponins and EKGs, but this has a benefit ultimately. And then the same thing with syncope as well. You just have fewer people that are staying in the hospital, reduced length of stay, and they get discharged earlier too, without any adverse effects happening to them. And same with asthma as well too. And so kind of going like head to head, there are a lot of different like studies and trials that have been done, but kind of across the board, the primary outcome ends up being better for your OBS patients compared to your inpatient admissions. AFib, CHF, syncope, TIA, all these different diagnoses. And then lastly, I kind of want to touch on this, but probably the most interesting article that I read over the course of this research was this qualitative study that was published in Annals in like the 2018, 2019, which basically like interviewed these EM providers, both in the US, also in the UK. And they asked them kind of what their perspective was about the use of OBS in general. And then physicians obviously expressed cynicism about like having to deal with administration and financial growth, but they're fairly appreciative of the fact that like this is expediting patient care, especially for people who won't be able to follow up or don't have access to this. But the bigger thing that was kind of highlighted in this paper was just this appreciation for OBS as like a safe space for managing social uncertainty, how this interfaces with clinical medicine, right? In a sense, you're caring for patients outside of like these very clear protocols, but people were more satisfied because you're able to like tend to patients in a safe way, and then they're being monitored and they're being discharged with a plan that's actually beneficial for them, right? And I think we have a lot of these patients in county where we kind of accept that we lose money because they're taking place from people who don't have insurance who you could bill for, but this is kind of why we're here, right? We're taking care of people and trying to figure out what's best for them. And so I think there's a lot of good that we do for these patients when they're placed on OBS for placement or like inability to ambulate, because we're able to like really expedite the care for what they need. And so beyond its roots in protocols for specific conditions and its use for, to protect revenue from inpatient utilization audits, there's some additional kind of value in OBS besides just like these two things, really. And so kind of the takeaways here, right? There are definitely some patients who are financially harmed with large out-of-pocket costs. And so think about that too, but obviously, please OBS patients who don't have billable diagnoses, but definitely just need to stay further monitoring. OBS has been shown to have improved clinical decision-making for patients, fewer risky discharges, right? There are economic and operational benefits to the hospital. And then don't forget the fact that we're here to take care of patients, and sometimes you just need more time for them so they can see social work, they can have PTC come and see them, or you just need more time to talk to family. And OBS is a way to do that safely for the patient as well. Here are my references, and if you guys have any questions for me.
There's a couple of questions in the chat, actually.
Hi, Neupane, it's Eli. Can you hear me?
Yeah, I can hear you.
Hi. Phenomenal job with that presentation, dude. I just wanted to add one thing. So for our residents who may leave here and go work in an institution that's privately based, you'll see another way they utilize OBS in the emergency room. For any patient who may have a length of stay for more than 3 hours under your care, they actually put them in observation, but under your own name, meaning you keep the patient, but they just go into observation status. And these are the patients who obtain CTs of the abdomen pelvis, patients who are ETOH abuse, and you need to wait for them to sober up. And they figured out that they can actually improve their RVU billing by doing that. And that's really for the places where it's a split salary, where a percent of your base pay is provided and the other percent you have to earn through RVU. That little trick can be used to generate some more income on your end. So that's great. And keep that in mind just in case you go out into the private world. And the other question we often get is, okay, what happens when a patient goes through OBS and then is admitted? So billing wise, that on the hospital side still gets bundled into a DRG, meaning it's going to be one payment at the end, even though the patient went through OBS. What's good to know is that on the provider end, the RVU component is a little bit higher if they've had a stay in observation as well. So those are just two things I wanted to add, but you did a phenomenal job with this presentation.
Thanks, Dr. Yusuf. The other thing is in Canada, Australia, and England, you actually have like a cap where if your patient's in the ED for 4 hours, they automatically get placed in like a different part of the ER that's like dispo focused. And so, you don't have like the 18-hour length of stay here waiting for CAT scan or MRI. That patient will be obs almost immediately as like a hospital policy. And so it's interesting to see how like different institutions kind of like have these protocols in place. And then Monisha had a point where she was saying that the ED obs unit does not see the reimbursement for patients who are upgraded because it gets bundled in patient admission. Yeah. And then Robbie had a question about whether there are any diagnoses or procedures that should not be placed on OBS for financial reasons, i.e. less reimbursement for hospital or higher cost for patient like endoscopy.
So I can add to that if you want, Neupane. One of the classic ones is new onset AFib. I created a whole protocol for that at my last institution. Months of work, got all the way up to the CMO, where he laughed at me and rejected it because essentially the hospital still makes way too much money off of new onset AFib. And that's why we haven't implemented it here. So unfortunately, we still have to play the billing game with the higher levels of the hospital. So that's one example.
Yeah, and same with new onset CHF as well. But in terms of like the endoscopies and procedures, technically like OBS shouldn't really be a place for people that are pre-procedural necessarily. I mean, you can make a case for like billing purposes, but like no one should be placed on OBS so they can then go to surgery, at least from like my research.
Yeah, and I think it depends on the procedure itself. Like the ones that you can be discharged after pretty quickly that are not like specifically on a surgical service, I think might be a little bit better to be on OBS, like a subspecialty service, but like ones that would be under a medicine subspecialty. But yeah, I definitely agree for the surgical ones. I also wanted to, I guess, speak a little bit more to the TIA one, because I know that's a little bit more of a controversial one. And specifically at county intern year, I took a look at all of the patients that were ALOCed, which is patients that are basically considered like social admission within 48 hours of their initial arrival. And the largest percentage of those patients were actually our neuro patients. And they were sitting on the floors for like 7 or 8 days here at county for literally an MRI and a carotid Doppler. So in that sense, a lot of other hospitals have a TIA protocol just to prevent this. So I guess like I would like to voice that I'm appreciative that we have that now to make sure that our patients actually get the things that they need and get out of here without just sitting on the floors for years.
Yeah, and it's not really a billable diagnosis in most places either, actually, for TIA. And so it's a really good point. Any other questions or comments?